They made an antidepressant, gas stations turned it into a high. The bottles were small enough to fit in a jacket pocket. Bright labels, cheerful fonts, names like Neptune's Fix and Tiana and Zaza Red. They sat in a wire rack beside the register at a gas station on Route 18 in Akron, Ohio, between the beef jerky and the phone chargers, priced at $19.99 each. Nobody asked for ID. Nobody asked questions. A man in a grey fleece jacket picked up 3 of them on a Tuesday afternoon in October 2019, paid cash, and was back in his car before the receipt finished printing. His hands were already shaking before he opened the first one. That detail matters, because shaking hands at 2 in the afternoon in a gas station parking lot, buying something off a wire rack, that is not the image most people carry when they think about addiction. No darkened alley, no whispered transaction, no needle, just a man in a fleece jacket, a legal product, and a body that had learned to need it. Before we continue, subscribe to the channel if you enjoy these stories. Write in the comments where you're watching from and what time it is. I always find it fascinating to see people from around the world united by one story. What he was buying was called Tianeptine, and almost nobody in the United States had heard of it. That was about to change. In 2014, poison control centers across the United States began receiving calls they didn't have a clear category for. The patients weren't describing typical opioid overdoses. They weren't describing stimulant crashes. The symptoms were scattered and severe. Seizures, vomiting, rapid heart rate, a crushing, almost unbearable anxiety, and in the worst cases, a kind of full-body shutdown that had emergency room doctors reaching for protocols that didn't fit. When toxicology screens came back, the results listed a compound most American physicians had never encountered in a clinical context. 40 calls that year, then 80. Then, by 2017, the number had tripled. Poison control specialists started quietly comparing notes. The calls were clustered, not randomly distributed across the country, but concentrated in specific regions, specific states, specific zip codes. The Midwest, the South, communities that had already spent a decade hemorrhaging people to opioid overdoses. Places where OxyContin had become heroin, and heroin had become fentanyl, and families had grown accustomed to the specific weight of that kind of grief. In those places, something new had arrived, and it was sitting in plain sight on gas station shelves, legal under federal law, unscheduled, unregulated, and selling fast. The substance had a legitimate history. It was not cooked in a bathtub. It was not invented by a cartel chemist. It had been synthesized in a proper laboratory, studied by real scientists, and approved as a prescription antidepressant in more than 60 countries. Doctors in France had been prescribing it for 3 decades. Romanian psychiatrists used it. Argentinian clinicians trusted it. It had peer-reviewed studies, clinical trials, a known mechanism of action, a package insert translated into a dozen languages. It also bound to the same receptors in the brain as heroin. Not at therapeutic doses, not the way a doctor in Paris would use it, but the dose on those gas station bottles wasn't the therapeutic dose, it was sometimes 60 times higher. And at that level, the receptor binding wasn't theoretical. It wasn't a footnote in a pharmacology paper. It was real, it was fast, and it felt, according to the people who experienced it, like something between a strong opioid and a short, sharp jolt of relief from a pain they hadn't been able to name. The withdrawal started in under 3 hours. That fact alone should stop anyone who reads it. 3 hours. The half-life of Tianeptine in the body is roughly 150 minutes. The brain doesn't wait. The moment the drug begins to clear, the absence registers, not as mild discomfort, but as emergency. Muscles cramp, sweat soaks through clothing, The chest tightens as if something heavy has been placed on it. In severe cases, the withdrawal produces seizures. In documented cases, it produced death. And for years, this was happening in gas station parking lots across America, hidden inside cheerful little bottles with names that sounded like vitamin supplements. By 2020, 17 states had moved to restrict or ban tianeptine. Georgia, one of the hardest hit states, logged over 500 poison control calls in a single year. Alabama had been the first to act back in 2014, recognizing the danger early and scheduling the drug before most of the country knew what it was. But the federal government had not moved. The Food and Drug Administration had not scheduled it. The Drug Enforcement Administration had not classified it. Under the patchwork of state laws and the broad, permissive architecture of federal supplement regulation, tianeptine remained legal in most of the United States, a prescription antidepressant in France, a scheduled substance in Alabama, and a dietary supplement in 38 other states. The vendors knew this. They knew it precisely. The bottles kept changing names. When one brand attracted attention, another appeared. The active ingredient stayed the same, the wire rack stayed full, and the calls to poison control kept coming, not from back alleys, not from the populations that show up in the standard narratives about drug crises, but from school teachers and veterans and construction workers and people who had started taking tianeptine because they were anxious or depressed or in chronic pain and had found something that worked and hadn't understood, couldn't have understood because nobody told them, what that relief was actually costing. The man in the grey fleece jacket on Route 18 was not, by any obvious measure, the kind of person this was supposed to happen to. He had a job, he had a mortgage, he had a classroom full of 10th graders who thought he was one of the better teachers in the building. His name was Ryan Kowalski, and his story doesn't begin in that parking lot. It begins much earlier, and it begins, like most stories of this kind, with something that genuinely helped. But before Ryan, before the gas stations and the poison control calls and the 17 states scrambling to respond, there was a laboratory, there was a scientist, there was a problem that needed solving, and a compound that seemed, for a brief and genuinely hopeful moment, like the answer. This is the story of how that compound travelled from a research institute in Paris to a wire rack in Ohio, how it passed through 60 years of science, policy, exploitation, and institutional failure. How it became, in the precise clinical language of the emergency physicians who kept seeing it arrive in their waiting rooms, one of the most underreported drug crises in modern American history. And how, at every single step of that journey, someone had the information they needed to stop it, and didn't. Paris, 1960. The city was still rebuilding, not physically, that work was mostly done, but psychologically, in the quieter and slower way that populations recover from occupation and war, and the specific shame of having survived both. Depression was everywhere and mostly invisible. It didn't have the cultural vocabulary it has now. It was called exhaustion, or weakness, or simply the way things were. Psychiatry in France was dominated by psychoanalysis, the couch, the talking, the slow excavation of childhood. Medication existed, but it was blunt and brutal, and the doctors who used it knew it. The drugs available for depression in 1960 were, by modern standards, barely controlled poisons. The first generation of antidepressants, the tricyclics and the MAO inhibitors, had been discovered almost by accident in the 1950s, when researchers noticed that certain tuberculosis drugs made patients inexplicably cheerful. The pharmaceutical industry grabbed that observation and ran with it. By 1960, there were pills that genuinely lifted mood in severely depressed patients. That was real. That was significant. but the side effects read like a list of contraindications for a different disease entirely. Dangerous spikes in blood pressure, heart rhythm disturbances, seizures, sedation so heavy that some patients spent more hours unconscious than awake, dry mouth so severe it cracked the lips, constipation, confusion, a kind of chemical fog that lifted the depression but replaced it with something almost as disabling. Doctors prescribed them anyway. There was nothing else. Inside a research division of the French Society of Medical Research, the Institut de Recherche Servier, operating out of a facility in the western suburbs of Paris, a team of chemists was working on the problem from a different angle. The institute was not a university. It was not a government agency. It was the research arm of a private pharmaceutical company founded by a physician named Jacques Servier, who had built his business on a simple conviction that the drugs available for psychiatric and cardiovascular conditions were inadequate, and that the gap between what existed and what was possible represented both a medical failure and a commercial opportunity. Servier himself was a complicated figure, a trained physician, a decorated veteran of the French resistance, a man who wore his convictions loudly and built an institution around them, but who also operated in the deeply competitive, often opaque world of mid-century European pharmaceutical development, where the line between scientific ambition and financial calculation was rarely clean. His chemists were good. That is not in dispute. Through the late 1950s and into the 1960s, the team synthesized hundreds of compounds, variations on the tricyclic structure, modifications at different molecular positions, attempts to keep what worked and strip away what didn't. Most failed. The waste bin of pharmaceutical research is full of compounds that looked promising on paper and did nothing, or did something unexpected and terrible in living tissue. The team catalogued each failure, adjusted, and continued. Then, at some point in the early 1960s, the precise date varies depending on the source, and Servier's internal records from this period are not fully public. A compound designated S1574 produced results that stopped the team. It worked on depression. That much was consistent with what they'd seen before. But the mechanism was wrong. To understand why that mattered, a brief stop is necessary, because the mechanism is everything. It is the detail that makes Tianeptine not just unusual, but genuinely scientifically strange, and it is the detail that explains, decades later, why the compound could be sold as an antidepressant in France and consumed as an opioid substitute in Ohio without either description being entirely false. Every antidepressant works on neurotransmitters, the chemical messengers the brain uses to communicate between cells. The dominant theory in the 1960s, and still a major framework today, was that depression involved a deficiency of certain neurotransmitters, particularly serotonin and noradrenaline. Fix the deficiency, fix the mood. The tricyclic antidepressants worked, imperfectly, brutally, by blocking the reuptake of those chemicals, keeping them active in the space between neurons longer than they would otherwise remain. S1574 did not do that. In fact, it did the opposite with serotonin. It enhanced reuptake rather than blocking it. By the prevailing theory of the time, that should have made it worse for depression. It should have deepened the deficit. It had no business working. It worked. This paradox would occupy researchers for the better part of 4 decades. Later studies would suggest that tianeptine's antidepressant effect operated through a different pathway entirely, modulating glutamate, the brain's most abundant excitatory neurotransmitter, and producing structural changes in neurons under chronic stress. The serotonin effect might have been largely irrelevant to its therapeutic action. But in 1960, none of that framework existed. The researchers had a compound that relieved depression through a mechanism they couldn't explain. and they made a decision that would define the next 60 years of tianeptine's history. They kept going. Development took decades. That is not unusual in pharmaceutical research. The gap between a promising compound and an approved drug is long, expensive, and littered with failures at every stage. Clinical trials, safety studies, regulatory submissions. By the time tianeptine was approved in France as a prescription antidepressant, under the brand name Stablon, the year was 1987, 27 years after the compound was first isolated. The drug that reached pharmacies was presented as a genuine advance, clinically effective for depression, potentially useful for anxiety, carrying a side effect profile that was, compared to the tricyclics it partly replaced, dramatically cleaner. No dangerous cardiac effects at therapeutic doses, no severe sedation. Patients could take it and function. That was not a minor thing. For a generation of depressed patients in France who had watched friends or family members shuffling through their days in a tricyclic fog, a medication that worked without dismantling cognition felt like a breakthrough. The approved dose was precise and conservative, 12.5 milligrams 3 times a day, taken before meals. Total daily dose, 37.5 milligrams. The schedule mattered. The spacing mattered. The restriction to that specific dose range was not arbitrary. The Servier researchers knew from their own pharmacokinetic data that the drug cleared the body fast. Its half-life was approximately 150 minutes, which meant it was substantially gone within 2.5 hours of being taken. What that data did not prominently address, what would not become a subject of serious public discussion for another decade, was what happened at doses above the therapeutic range. What happened to the mechanism when the amount was not 12.5 milligrams, carefully timed and clinically supervised, but 5 times that, or 10, or 50? That question had an answer. The answer existed in the pharmacology. But in 1987, when Stablon arrived in French pharmacies and physicians began writing the first prescriptions, the question wasn't being asked loudly. It was there in the data, waiting. A researcher at Servier's own institute had noted in an internal document from the mid-1980s that as 1574 showed measurable affinity for a specific class of receptors in the brain, receptors whose name, at the time, was beginning to appear with increasing frequency in neuroscience literature. Mu-opioid receptors, the same receptors activated by morphine, by heroin, by every opioid painkiller that would, in the following decades, reshape and devastate the pharmaceutical landscape of the Western world. The affinity was low. At 12.5 milligrams, it was essentially clinically irrelevant. At higher doses, the mathematics changed entirely. That document was not part of the public regulatory submission. Whether it was considered, filed, overlooked, or deliberately set aside is a question the available public record cannot fully answer. What the record shows is that Stablon was approved, launched, and prescribed, and the mu-opioid receptor binding remained for the next 15 years, a detail known to specialists and invisible to almost everyone else. The drug went to market. The patients began taking it, and in the clinics and psychiatry offices of Paris and Lyon and Marseille, the early reports were largely positive. But somewhere in the pharmacology data, sitting in a filing cabinet in the western suburbs of Paris, was a number that nobody had explained yet. Stablon moved quietly at first. France, Belgium, the Netherlands, Western European markets where Servier had established distribution, and where psychiatrists were already familiar with the compound from clinical trial data. The early prescribing physicians were cautious in the way that physicians tend to be with new psychiatric medications. Start low, monitor carefully, adjust if needed. For most patients in those first years, the drug performed as advertised. Depression lifted, anxiety eased, the side effect profile stayed clean. A psychiatrist in Bordeaux who had spent a decade watching tricyclic patients struggle through medicated fog described Stablon in a 1989 letter to a colleague as the first antidepressant he'd prescribed without a persistent sense of reservation. That letter was private, but the sentiment spread through the profession in the way professional sentiment does, through conferences, through referrals, through the slow accumulation of positive clinical experience that eventually becomes consensus. Then the wall fell. The collapse of the Soviet Union in 1991 opened Eastern Europe to Western pharmaceutical markets almost overnight. Countries that had operated behind closed medical systems for 40 years suddenly had access to drugs their physicians had only read about in restricted journals. Servia moved fast. The company had been expanding aggressively through the 1980s and understood that the newly opened markets of Poland, Romania, Hungary and Bulgaria represented an extraordinary opportunity, not just for Stablon, but for their entire portfolio. Tianeptine arrived in Romania in the early 1990s. The timing was significant. Romanian psychiatry in that period was in a state of reconstruction, emerging from the Ceausescu era, during which psychiatric diagnosis had been weaponized as a tool of political control, and the profession had been systematically distorted. Young psychiatrists trained in the new system were hungry for legitimate pharmacological tools. Western drugs carried an implicit prestige. Stablon, with its clean profile and its French pedigree, found an enthusiastic reception. One of those young psychiatrists was a woman named Dr. Marta Wisniewska, practicing in Bucharest. She was 31 years old when she wrote her first Tianeptine prescription. Her patient was a 58-year-old factory foreman who had developed severe depression following the closure of the plant where he had worked for 22 years, one of thousands of state enterprises dismantled in the economic chaos of post-communist transition. He had been unable to sleep for 11 weeks. The older antidepressants available to her carried cardiac risks she was unwilling to accept given his age. Stablon was the cleanest option she had. Within 3 weeks, he was sleeping again. Within 6, he described feeling for the first time in months like himself. Dr. Wisniewska noted this carefully. She noted everything carefully. It was a habit she'd developed during her training, when record-keeping had felt like the only honest act available to her in a system designed around dishonesty. She began prescribing Tianeptine more broadly. It worked consistently, and her confidence in it grew with each successful case. She did not notice in those early years what was happening at the margins of her patient list. She was too focused on the center. Across the Atlantic, the United States was having a different kind of pharmaceutical moment entirely. The 1990s were the decade of the SSRY. Prozac had arrived in 1988 and reshaped psychiatric medicine. Antidepressant prescribing exploded, and the FDA's approval process was the gate through which any new psychiatric drug had to pass before reaching American patients. Tianeptine never tried to pass through that gate. Servia made no FDA submission for Stablon in the 1990s. The company's American commercial focus lay elsewhere, and the clinical data package for Tianeptine, while sufficient for European regulatory bodies, contained gaps that would have made an FDA approval process lengthy and uncertain. So Tianeptine simply didn't exist in the United States. Officially, American physicians didn't prescribe it. American pharmacies didn't stock it. American patients didn't receive it. For the entirety of the 1990s, if a person in the United States had heard of Tianeptine at all, it was because they had a connection to Europe or had stumbled across a reference in specialist literature. The drug was invisible in America, and that invisibility would, in the following decade, become one of the central facts of its American story. Because invisible is not the same as absent. The internet arrived in the mid-1990s and did something to pharmaceutical knowledge that nobody had fully anticipated. It made it horizontal. Information that had previously moved only between credentialed professionals, prescribing guidelines, pharmacological studies, case reports from obscure journals, suddenly moved between anyone with a modem and enough curiosity. By the late 1990s, there were forums dedicated to the discussion of psychoactive substances with a depth and specificity that rivaled academic literature. Some of those forums were driven by genuine scientific interest. Some were driven by something more direct. Heroin launched in 1995. Blue Light followed. These were websites where people documented their experiences with drugs, legal, illegal, and everything between, with a clinical precision that reflected a community genuinely interested in pharmacology, not just in getting high. The tone was often cautious. Contributors warned each other about dangerous combinations. Harm reduction was the operating philosophy. And somewhere in those forums, in the late 1990s and early 2000s, posts about Tianeptine began to appear. The early reports were tentative. Someone had obtained Stablon tablets while travelling in Eastern Europe. Someone else had ordered it from an online pharmacy, operating out of a jurisdiction with loose export controls. The initial doses were low. People were treating it as an antidepressant, which is what it was. But one of the early contributors noted something that other readers flagged immediately. At a dose significantly above the prescribed amount, the effect changed character entirely. It wasn't the gradual mood lift of an antidepressant. It was something faster, something warmer, something that arrived within 20 minutes and felt the description that appeared most frequently across multiple independent posts, like a mild opioid, not the crushing sedation of high-dose heroin, cleaner than that, a loosening of something tight in the chest, a brief and specific relief from a background anxiety that most of the contributors described as their normal state. The posts multiplied. The dose information became more specific. The community began comparing notes with the methodical rigor it applied to everything. And then someone asked the obvious question: if it works like an opioid, does it also stop working like one? The answers came quickly, and they were not reassuring. Yes, tolerance developed. Yes, the dose crept upward over time, the original amount producing less and less effect. Yes, stopping was not comfortable. Some contributors described stopping as deeply uncomfortable, lasting days, characterized by anxiety, muscle pain, and a restlessness that prevented sleep. That thread was posted in 2003. It had 47 replies. It was read, over the following years, by tens of thousands of people. None of those readers included anyone at the FDA. While the forums catalogued their findings, the legitimate pharmaceutical geography of Tianeptine was expanding in a different direction. By the early 2000s, Stablon was available by prescription in more than 60 countries: France, Belgium, most of Eastern Europe, Russia, much of Latin America, parts of Asia. In each of those markets, it operated as what it had been designed to be: a prescription antidepressant dispensed by pharmacists, monitored by physicians, used within the approved dose range. But the approved dose range was not universal. In Russia and several Eastern European countries, the prescribing guidelines were less tightly enforced than in France. A Russian patient could, in practice, obtain multiple prescriptions from different physicians, a practice known as doctor shopping that was also common in American opioid markets. Reports of patients consuming 10, 15, 20 tablets per day instead of the prescribed 3 began appearing in Russian addiction medicine literature by the early 2000s. In France itself, something quieter was happening. The pharmacies were starting to notice patterns. Certain patients were refilling their Stablon prescriptions early, not by a few days, but by weeks. One pharmacist in Lyon documented a patient who attempted to fill a monthly supply 11 days after the previous fill. When the pharmacist declined, the patient went to a different pharmacy 3 blocks away. The pharmacist filed a report. The report went to a regional health authority. The regional health authority noted it and forwarded it to the national level. For the next several years it sat. Back in Eastern Europe, Dr. Wisniewska was prescribing Tianeptine to roughly 40 active patients by 2002. The drug had become one of her most reliable tools, dependable in its efficacy, manageable in its profile. She'd seen no serious adverse events. Her patients, overwhelmingly, had improved. Then one of them didn't come in for a scheduled appointment. Then another. When she eventually reached the first patient by telephone, he described feeling unwell whenever he tried to reduce his dose, intensely unwell, in ways that didn't match any side effect profile she'd been given. He had not reduced the dose, he clarified. He had tried to and found he could not. Wisniewska scheduled an emergency appointment. She also, that same afternoon, pulled the Servier prescribing information for Stablon from her filing cabinet and read it again, front to back, looking for the section on dependence and withdrawal. The section was 3 sentences long. It described Tianeptine's dependence potential as low and its withdrawal effects as mild. It recommended a gradual taper when discontinuing, without specifying a protocol. It did not mention the mu-opioid receptor. It didn't mention the 150-minute half-life as a dependence risk factor. It did not contain the word opioid anywhere in its text. Wisniewska read those 3 sentences twice. Then she opened a new file and started writing. She didn't know what she was documenting yet. She didn't have enough cases. What she had was one patient who couldn't reduce his dose, and a prescribing document that described this as unlikely, and the particular unease of a physician who has learned something that her reference materials haven't caught up to yet. Somewhere in Ohio, in a city that had not yet entered this story, a boy named Tyler Harmon was 11 years old and riding his bike to school. His mother Desiree watched him from the front porch until he turned the corner and disappeared from view. Neither of them had heard of Tianeptine. There was no reason they would have. Not yet. Ryan Kowalski found Tianeptine on a Tuesday night in February 2015, somewhere between his 3rd hour of grading papers and his 2nd glass of whiskey, while scrolling through a Reddit thread about anxiety management that had started with breathing exercises and ended 40 comments deep, with someone describing a legal powder that had changed their life. He was 34 years old. He had been teaching high school history in Akron for 9 years. He was good at it, genuinely good, the kind of teacher students came back to visit after graduation, the kind whose classroom had a waiting list during course selection. He had also been anxious for as long as he could remember, in the specific, constant low-grade way that doesn't announce itself dramatically but instead runs beneath everything like a current, making each ordinary task carry slightly more weight than it should. The divorce had made it worse, not the divorce itself, that had been mutual and mostly quiet, but the apartment afterward, and the silence in it, and the way Sunday afternoons had started to feel like a physical pressure behind his sternum. He had tried 2 SSRIs. The first one flattened his mood so completely that he felt neither anxious nor anything else, navigating his classroom like a man behind glass. The second gave him insomnia severe enough that he spent 3 weeks teaching on 4 hours of sleep, which was worse than the anxiety had been. His psychiatrist had suggested a 3rd option. Ryan had not filled that prescription. The Reddit thread mentioned Tianeptine in a tone that was neither evangelical nor reckless, just specific. Legal in the US, available as a powder. A nootropic, technically, though the poster clarified that it had full antidepressant approval in over 60 countries. Dose carefully. Start low. The anxiety relief was noticeable within an hour. Ryan read the thread for 45 minutes. Then he opened a separate tab and ordered 10 grams from a US-based vendor for $28, with free 2-day shipping. The powder arrived in a small Ziploc bag inside a padded envelope. No logo, no instructions beyond a printed card that listed the product as Tianeptine sodium, research purposes only, and suggested a dose of 10 to 25 milligrams. Ryan had already calculated the therapeutic dose from his research, 12.5 milligrams 3 times a day. He measured 15 milligrams on a digital scale he'd bought specifically for this purpose, dissolved it in water, and drank it before his first class on a Wednesday morning. By third period, something had shifted. Not dramatically. Not the warm rush the forum post sometimes described. Something quieter. A loosening of the tension that normally sat between his shoulder blades through every teaching day. The low background noise of self-monitoring that accompanied each lesson. He could think without simultaneously tracking his own thinking. When a student in the back row challenged a date he'd given for the Missouri Compromise, he laughed instead of feeling the brief hot flash of defensiveness that usually arrived first. He drove home that afternoon and sat at his kitchen table for 20 minutes without doing anything in particular. Just sitting. It had been a long time since sitting quietly had not felt like an activity that needed to be justified. He ordered another 25 grams the following week. To understand what Ryan was experiencing and why it made complete sense to him and to thousands of people like him, it helps to understand what tianeptine actually does to the brain at therapeutic doses in the specific and measurable terms that the research from the 1990s and 2000s eventually produced. The prevailing antidepressant theory, fix the serotonin deficit, fix the mood, had always been incomplete. Depression and anxiety are not simply chemical deficiencies. They involve structural changes in the brain. Neurons under chronic stress literally shrink. Their connections weaken. Their ability to adapt deteriorates. The hippocampus, the region most associated with memory and stress regulation, physically contracts in people with prolonged depression. The prefrontal cortex, responsible for judgment and emotional regulation, becomes less active. These are not metaphors. They are visible on brain scans. Tianeptine, the research suggested, worked at this structural level. It appeared to protect neurons from stress-related damage, to preserve and possibly restore the connections that chronic anxiety eroded. It also modulated glutamate, the main excitatory neurotransmitter, in ways that reduced the hyperactive stress response that characterized anxiety disorders. The effect was not a chemical sledgehammer. It was closer to a stabilizer. At 12.5 milligrams 3 times a day, the mu-opioid receptor binding was minimal, present, measurable in laboratory conditions, but pharmacologically insignificant at that dose. The relief Ryan felt was largely real, largely neurological, and largely consistent with what a French physician in the 1990s would have recognized as a successful prescription outcome. This is important. Tianeptine at therapeutic doses was not a trick. It was not a placebo. It did what it was supposed to do. That is exactly what made the next part possible. By the summer of 2015, Ryan had been taking tianeptine for 5 months. His dose had increased to 25 milligrams twice a day, still above the recommended schedule but not dramatically so. He told himself it was because the 15 milligram dose had lost some of its edge, which was true. He did not examine too carefully why a drug that had been so effective in February now needed to be doubled by July. He simply adjusted and continued. The school year had gone well. His students' test scores were up. He had started running again for the first time since his late 20s, 3 miles 3 times a week, a habit he attributed in his own mind to the tianeptine restoring some baseline of motivation that the anxiety had suppressed. He kept the powder in a kitchen drawer between the batteries and the takeout menus, in its original Ziploc bag now replaced by a small amber glass jar he'd ordered for the purpose. Nothing about his life looked unusual to anyone observing it from the outside. What was invisible from the outside, the calculation that had begun running at the back of his mind every day, precisely 90 minutes after each dose, as the drug's 150-minute half-life began its descent. A low-grade awareness, a monitoring, not yet urgency, more like the way a person checks the gas gauge on a long drive through empty country, just keeping track, just making sure. He had not yet connected this monitoring to anything that required attention. In Bucharest, Dr. Marta Wisniewska was no longer just monitoring, she was documenting. The file she'd opened in 2002, after her first concerning patient, had grown, by 2005, into a folder containing notes on 11 individuals. Each case shared a structure: initial therapeutic success, gradual dose escalation driven by the patient rather than the physician, increasing difficulty reducing the dose when attempted, and withdrawal symptoms that the patients described with a consistency that ruled out coincidence. The withdrawal descriptions were specific, not the mild discontinuation effects noted in the Stablon prescribing information. Something more forceful, onset within 2 to 4 hours of a missed dose, peaking around the 6-hour mark, involving nausea, cramping in the legs and abdomen, a skin-crawling restlessness that some patients described as an inability to find any position that was tolerable, and an anxiety so acute it crossed into panic. Those were not SSRI discontinuation symptoms. Wisniewska knew what SSR discontinuation looked like. She had seen it in dozens of patients over the years. Uncomfortable, sometimes distressing, but manageable and typically delayed by days rather than hours. What her Tianeptine patients described happening within hours was something she recognized from a different category of clinical literature entirely. She began reading the opioid dependence research. The match was not ambiguous. By 2006, she'd submitted a case series to a Bucharest medical journal, not a major international publication, just the regional clinical bulletin that Romanian psychiatrists read. 8 cases, detailed, careful. Concluding that Tianeptine warranted closer monitoring for dependence potential, particularly in patients with prior anxiety or substance use history. She recommended a prescribing protocol, no more than 90-day supplies, mandatory check-ins before refills, gradual taper protocols documented in writing before any patient began treatment. The journal published it. The issue reached perhaps 300 readers. In Paris, Servia's pharmacovigilance department, the division responsible for tracking post-market safety signals, received a copy as part of their routine literature scan. The document was logged. It was noted. It was placed in a file. The prescribing information for Stablon was not updated. Across the Atlantic, the regulatory architecture that would eventually govern Tianeptine's American story was, in 2006, still pointing in a completely different direction. The FDA's attention through the mid-2000s was consumed by the accelerating crisis around prescription opioids, OxyContin's catastrophic overprescribing, the lawsuits, the mounting death toll, the congressional pressure. Tianeptine was not on any radar. It wasn't approved, wasn't prescribed, wasn't present in any pharmaceutical database the FDA routinely monitored. But there was a law. Passed in 1994, the Dietary Supplement Health and Education Act, DSHEA, pronounced like the word SHEA, had fundamentally restructured the regulatory relationship between the US government and the supplement industry. Before DSHEA, the FDA could treat novel compounds in supplements the way it treated drugs, requiring proof of safety before market entry. After DSHEA, the burden reversed. The FDA now had to prove a supplement was unsafe before it could be removed from sale. The supplement industry had lobbied intensively for this reversal, spending millions on a campaign that framed the legislation as protecting consumer freedom. It passed with broad bipartisan support. Its full implications took years to materialize. What DSHEA meant, in practical terms, was that any substance not already scheduled as a controlled drug could be sold as a dietary supplement as long as it didn't explicitly claim to treat a disease. The label couldn't say, treats depression. It could say, supports mood. It could say, promotes emotional wellness. It could say almost anything except the thing that was actually true. Tianeptine, never scheduled, never FDA approved, falling into the vast grey zone that DSHEA had created, fit this framework with a precision that seemed, in retrospect, almost deliberate. Nobody had planned it that way. In 2006, no American vendor was yet selling Tianeptine. The forums knew about it. The nootropics community discussed it. But the supply chain from chemical manufacturer to retail shelf had not yet assembled itself. It was assembling. Quietly, in warehouses and online storefronts, and the spreadsheets of small supplement companies testing margins on new products. Ryan Kowalski was still in his mid-20s, still married, still years away from the Tuesday night Reddit thread that would change the trajectory of his next decade. Tyler Harmon was a teenager in Macon, Georgia, whose most pressing pharmaceutical concern was the Adderall prescription he'd just received for ADHD, legally from a pediatrician, handed to his mother Desiree in a white paper bag with the pharmacy's logo printed on the side. The pieces were all present. They had not yet found each other, but in a small amber jar in a kitchen drawer in Akron, a powder was running low faster than it should have been. And Ryan Kowalski, measuring his morning dose with the precision he'd initially been so careful about, noticed that the amount he was measuring had, at some point he couldn't precisely identify, become larger than the amount he'd started with. He measured it anyway. He drank it anyway. The monitoring in the back of his mind quieted, for another 2 hours approximately before it started again. The paper arrived in the offices of the French National Health Authority, the Agence Française de Sécurité Sanitaire des Produits de Santé, known as AFSSAPS, sometime in 2001. It was not a dramatic document. It was a cluster of case reports from hospital pharmacists and addiction medicine specialists, assembled by a researcher at the University of Paris and submitted through the standard pharmacovigilance reporting channel that existed precisely for this kind of signal. 14 cases. Patients who had been prescribed Stablin for depression and had developed patterns of use that no longer resembled depression treatment. One patient was taking 40 tablets a day. The prescribed dose was 3. The researcher's notes on that case were clinical and precise. The patient, a 44-year-old man identified only by initials, had begun crushing the tablets and dissolving them in water for faster absorption. He had obtained prescriptions from 6 different physicians simultaneously, a logistics operation that required planning, coordination, and the kind of focused determination that severe physical dependence tends to produce. When the researcher's team had attempted a supervised taper, reducing his dose by 10% over 2 weeks, the withdrawal was severe enough to require hospitalization. AFSSAPS received this report and opened a formal review. That process took 3 years. The year 2000 had already produced a finding that should have accelerated everything. A study published in the European Journal of Pharmacology, not an obscure publication, not a fringe journal, but one of the main peer-reviewed outlets in its field, reported something that fundamentally reframed tianeptine's pharmacological identity. At doses above the therapeutic range, tianeptine demonstrated significant agonist activity at mu opioid receptors, not theoretical activity, not marginal binding, functional activation of the same receptor system that makes morphine work, that makes heroin work, that makes every opioid painkiller capable of producing both relief and ruin. The study was methodologically careful. Its conclusions were measured and specific. It did not claim tianeptine was dangerous at therapeutic doses. It claimed that above those doses, its mechanism changed character in a way that had significant clinical implications. The paper was cited in the 2 years following its publication by 11 other academic studies. None of those citations appeared in any regulatory document. None reached the FDA. The paper existed in the specialist literature the way important findings sometimes do, acknowledged by the people already looking, invisible to everyone else. In 2003, AFSSAPS completed its review and issued an internal recommendation. The finding was significant. Tianeptine showed a dependence profile inconsistent with its classification as a low-risk antidepressant. The authority recommended strengthening prescribing controls, limiting prescription quantities, requiring specialist involvement for long-term prescribing, adding explicit dependence warnings to the product labeling. Servier was notified. Discussions followed. The regulatory machinery moved at the pace regulatory machinery typically moves, which is to say, slowly, through channels, with revisions and responses and further consultations. The updated warning that eventually appeared on Stablon packaging used careful language. Cases of dependence have been reported, it said, in the measured phrasing of regulatory documents designed to inform without alarming. It did not say, this drug activates opioid receptors. It did not say, at high doses withdrawal resembles heroin discontinuation. It did not say, the half-life creates a craving cycle that self-reinforces within days. What the updated label did not contain was as significant as what it included. Ryan Kowalski's dose in the spring of 2016 was 150 milligrams a day. He'd arrived at this number gradually, over 14 months, through a series of small adjustments that each felt individually reasonable. The 25 milligram dose had plateaued, still present, still functional, but no longer delivering the quiet stability of the early months. He had increased to 35, then to 50, then to 75. Then, after a particularly difficult week in November when his father was hospitalized for a cardiac event, to the current level, spread across 6 doses taken every 2 to 3 hours throughout the waking day. He kept a small travel case in his desk at school. Inside, a pre-measured folded paper packet for each period, prepared every morning at 5:45 a.m. before he left his apartment. The monitoring in the back of his mind was no longer low-grade. It was constant, specific and precise. A clock running behind every lesson, every conversation, every faculty meeting, counting down to the next scheduled dose with the reliability of a second job. He had not told anyone. There was, in his framing of the situation, nothing yet to tell. He was managing a medical condition with a legal supplement. The dose had increased, yes. He would address that at some point. He was functional. His students were doing well. The classroom was still his. A colleague noticed once that he seemed distracted during a department meeting and asked if he was all right. He said he hadn't slept well. That was also true. The first American poison control call involving tianeptine was logged in 2000. A single case, in a state whose records from that period have not been fully published, likely involving someone who had obtained Stablon from an overseas pharmacy. It was noted. It was not flagged as a pattern. One call in a system that handles millions annually registers as noise, not signal. The noise stayed quiet for over a decade. Then, in 2013, a toxicologist named Dr. Christopher Hoyt at the Rocky Mountain Poison and Drug Center in Denver began noticing something in the call data he reviewed each month. Not a spike, nothing so visible. A trickle. 3 calls in a quarter, then 4, then 5, all involving a substance that his reference database listed as a foreign antidepressant with no approved American use. The callers described withdrawal symptoms. They described sourcing the substance online. They described doses measured in hundreds of milligrams rather than the tens that the foreign prescribing guidelines specified. Hoyt pulled everything he could find. The 2000 European Journal of Pharmacology paper, the French pharmacovigilance reports, Vishnevska's 2006 case series in the Bucharest Bulletin. He assembled a brief clinical summary and circulated it to colleagues at other poison centres across the country, asking if they were seeing similar calls. They were. The responses came back from Georgia, from Ohio, from Texas, from Florida, scattered but consistent. A pattern that had been invisible because no single centre had enough cases to register it was suddenly visible when the data was pooled. Hoyt drafted a report. His intent was to publish it in a clinical toxicology journal, to put the finding into the literature where physicians and pharmacists could see it. He submitted the report in early 2014. It was published in November of that year, by which point something had already happened that made the publication feel, to Hoyt at least, simultaneously necessary and insufficient. Alabama had moved first. In May 2014, the Alabama Department of Public Health had designated Tianeptine as a Schedule I controlled substance, the most restrictive category, reserved for substances with high abuse potential and no accepted medical use in the United States. The decision was driven by a single emergency room physician in Birmingham who had, over 3 months, treated 4 patients in Tianeptine withdrawal, severe enough to require IV fluids and opioid agonist therapy. 4 patients in 3 months, in one hospital, in one city. The physician had contacted the state health department directly with clinical notes, and the department had acted within 60 days. 60 days. 1 physician. 4 patients. That speed would not be replicated at the federal level for another 8 years. The Alabama scheduling created an immediate and specific consequence that nobody at the state health department had fully modelled. It made Tianeptine unavailable in Alabama while leaving it completely available in every neighbouring state. The supply didn't disappear, it relocated. Vendors in Georgia and Tennessee reported increased orders from Alabama zip codes in the months following the scheduling decision. The substance moved across state lines the way any banned substance moves. It followed the path of the least resistance, and the path of least resistance in the United States ran through the federal regulatory gap that DSHEA had created 2 decades earlier. This was the first sign of something that would define the entire American Tianeptine story. Every partial restriction accelerated the problem somewhere else. The year 2014 was also when the American retail market for Tianeptine properly ignited. The trigger was supply. Chinese chemical manufacturers, who had been producing Tianeptine as a bulk powder for the legitimate pharmaceutical supply chain since the 1990s, had by 2012 begun offering it on business-to-business platforms accessible to any company with a verified commercial account. No prescription required, no pharmaceutical license required. Minimum order quantities that were large by personal use standards, but trivial by manufacturing ones. A kilogram of Tianeptine sodium, sufficient to produce thousands of doses for a few $100s. American supplement companies noticed. The margins were extraordinary. A kilogram of Tianeptine sodium purchased wholesale for $400 could be repackaged into individual 750 milligram bottles, already 50 times the therapeutic dose, and sold retail for $15 to $20 each, yielding gross revenues of $20,000 from a $400 input. The overhead was a label, a bottle, and a shelf. The first major American brand was called Zaza Red. The label was bright. The font was bold. The bottle sat comfortably in a palm and looked, at a glance, like the kind of energy supplement sold in gyms. The active ingredient was listed on the back in small text as Tianeptine sodium. The disclaimer read as DSHEA required, not intended to diagnose, treat, cure or prevent any condition. The first shipments went to smoke shops and gas stations in Georgia in the spring of 2014. They sold out within days. The vendor ordered more, then more again. The reorder quantities tripled over 6 months, then tripled again. The distributor's records, which would later appear in a court filing and be cited in an FDA document, showed that by December 2014, Zaza Red was being stocked in over 200 retail locations across the American South. Christopher Hoyt's paper, published that same November, documented 16 Tianeptine-related calls to US poison centers over the preceding year. He wrote in his conclusion that the number likely represented significant underreporting given clinician unfamiliarity with the substance. He was right, and he was not yet close to understanding by how much. In Bucharest, Dr. Vishnevska received a copy of Hoyt's paper through an email listserv for addiction medicine researchers. She read it in one sitting. The cases he described, the dose escalation, the rapid onset withdrawal, the opioid-like symptom profile, were identical to what she had documented 8 years earlier in her regional bulletin. Same drug, same mechanism, same pattern, different continent. She wrote to Hoyt directly, attaching her 2006 case series. He replied within 48 hours. They exchanged a series of technical emails over the following weeks, comparing notes, aligning their clinical observations, discussing what a coordinated international case series might look like. At the end of that exchange, Hoyt asked her one question that she found she could not immediately answer. Had Servier ever formally responded to her 2006 publication? She went back through her files. There was no response from Servier. There was no acknowledgement from any national regulatory body outside Romania. There was a note, in her own handwriting, recording a phone call she'd received 3 weeks after publication from a medical affairs representative at a pharmaceutical distributor who had suggested her sample size was too small to support her conclusions and recommended she consider the limitations of retrospective case series methodology before pursuing further publication. She had noted the caller's name. She had also noted that the caller had not identified which company they represented. She sent Hoyt the name. He Googled it. The result appeared in 4 seconds. The name appeared on the website of a company that distributed Stablon in Eastern European markets. Neither of them said anything about it directly in their subsequent emails, but the exchange ended there, and both of them, in their separate cities, sat with what that 4-second search had produced. The question it opened was not a small one, and neither of them had an answer. Georgia, 2015. The state that would become the American epicenter of the Tianeptine crisis was, in that year, already saturated. Zaza Red had expanded beyond smoke shops into gas stations, convenience stores, and the kind of small neighborhood markets that stock whatever sells and ask few questions about why. The wire racks holding the bottles appeared near registers, at eye level, beside lottery tickets and phone chargers, positioned, whether by design or instinct, at exactly the point where a person makes an impulsive decision while already committed to a purchase. The customer base was not what the label implied. Energy supplement buyers browse. Tianeptine buyers returned with a specificity that the store owners noticed. Same faces, same days, same time of day, sometimes twice in the same afternoon. One gas station owner in Macon later recalled a regular customer who came in every morning at 7 a.m. and every afternoon at 2 p.m., always bought 3 bottles, always paid cash, always left without making eye contact, every morning, every afternoon, for 8 months. Tyler Harmon was 18 years old when he first encountered Zaza Red in the spring of 2015. His path to that wire rack was not unusual for his generation in Bibb County, Georgia. He had been prescribed oxycodone the previous year following a knee surgery, a routine procedure, a standard prescription, 30 tablets of 10 mg oxycodone with 2 refills. The surgery healed. The prescription ran out. What didn't run out was the absence the oxycodone had filled. Not pain exactly, but a background noise in his nervous system that the drug had quieted so completely that its return felt louder than it had before he'd ever taken the first tablet. His physician declined a further refill. This was 2014, when prescribers across the country were beginning to feel the pressure of opioid oversight, tightening their prescribing in response to guidelines that had arrived a decade too late for the patients already dependent. Tyler was not, by any clinical measure, a chronic pain patient. He was a post-surgical teenager with a healed knee and a nervous system that had been recalibrated by 3 months of opioid exposure. He tried heroin once, in the fall of 2014. He told his mother it was the worst decision of his life. He told her this directly, sitting at the kitchen table in their house on Wimbish Road, a detail Desiree Harmon would recount years later to anyone who asked. Because she wanted people to understand that Tyler knew. He wasn't naive. He wasn't reckless in the way the public narrative about young drug users tends to assume. He was looking for something that wasn't heroin, something legal, something manageable, something he could control. Zaza Red was all 3 things, right up until it wasn't. His first bottle cost $15. The effect arrived faster than he expected. Within 20 minutes, a warmth behind the sternum, a loosening of the specific tension that had accumulated in his body since the oxycodone prescription ended. It wasn't identical to oxycodone, cleaner somehow, less heavy, but occupying the same general space in his nervous system, quieting the same frequency. He bought a second bottle that afternoon. By the end of the first week, he was spending $90 a day. By the end of the first month, $150. The escalation was not slow. Tianeptine's 150-minute half-life compressed the tolerance-building process that took weeks with longer-acting opioids into days. The body adapted faster because the drug cleared faster. Each time the substance left, the absence registered as emergency. Each time the emergency was answered with another dose, the baseline shifted slightly upward. The math was relentless and it only moved in one direction. Desiree noticed the money first, then the schedule, the rigid, non-negotiable rhythm of Tyler's days, organized around intervals she didn't yet understand. Then the bottles, which she found in his jacket pocket while doing laundry, bright and small and labelled with a name that meant nothing to her. She Googled it. The first result was a vendor site with a cheerful header and a 5-star review section. The second result was a news article from Alabama about the state's scheduling decision. The third was a forum post describing Tianeptine withdrawal as worse than heroin. She was standing in the laundry room when she read that. She stood there for a long time. Ryan Kowalski's school year ended in June 2016, with his students scoring in the top quartile of the district on state history assessments. His department head praised him in a written evaluation. His classroom had a waiting list, as usual, for the following year's course selection. He accepted these facts with the same quiet efficiency with which he managed everything that summer, functionally at surface level, without allowing any of it to penetrate too deeply. His daily dose had reached 250 milligrams. The amber jar on his kitchen counter was now supplemented by a second jar, kept in his car's center console, and a small folded envelope in his wallet for what he'd begun mentally categorizing as emergencies. An emergency was any situation, a long faculty meeting, a traffic jam, an unexpected errand, that threatened to push him past the 2.5-hour window between doses. He had not had an unmedicated afternoon since March. The online vendor he had used since 2015 had recently changed its product formulation from tianeptine sodium to tianeptine sulfate, a slightly different salt form that the vendor described in a newsletter as offering extended release properties. What the newsletter did not explain, and what Ryan learned from the forums, was that the sulfate form absorbed more slowly, which meant the peak effect was lower but the duration marginally longer, and that some users found they needed to increase their dose to achieve the same result. He increased his dose. The vendor's newsletter also mentioned in a section titled Community Updates that several states had recently moved to restrict tianeptine and that customers in those states should be aware of potential shipping delays. Ryan was in Ohio. Ohio had not restricted it. He filed this information away and ordered a larger quantity than usual. A 100-gram bulk purchase, enough to last him, at his current dose, approximately 3 months. He told himself this was economical. The state-by-state regulatory response to tianeptine between 2014 and 2018 was a study in the specific dysfunction created when federal inaction meets a mobile commercial product. Alabama had moved in 2014, Arkansas followed in 2015, Indiana in 2019. Each state that scheduled tianeptine created an immediate pressure differential. Demand didn't disappear, it redirected. Vendors in unrestricted states saw their sales volumes increase following each neighboring state's ban, a pattern documented in shipping records that later appeared in litigation. The vendors adapted their logistics accordingly. When a state moved toward restriction, distribution shifted to fulfillment centers in states with no scheduled status. Online sales, which crossed state lines invisibly, continued uninterrupted regardless of destination. A customer in Alabama could order tianeptine online the day after the state banned it and receive it in 3 days. The scheduling created legal risk for in-state retailers, but posed essentially no barrier to the online supply chain. Meanwhile, the brands multiplied. Zaza Red remained the dominant name in the South, but Neptune's Fix appeared in the Midwest. Pegasus was sold in Texas. Tiana, the name's spelling slightly altered, presumably to complicate search results, showed up in Florida. Each brand had its own label, its own color scheme, its own carefully worded disclaimer. The active ingredient was identical across all of them. The dose in each bottle was not therapeutic. It was, in every case, pharmacologically designed to produce opioid receptor activation. Whether that was known to the sellers is a question the documentary record eventually answered, though not until several years later. Desiree Harmon spent the summer of 2016 trying to get Tyler into treatment. This sentence contains more than it initially appears to. Getting someone into addiction treatment in Bibb County, Georgia, in 2016 meant navigating a system that had been constructed primarily around traditional opioid dependence, heroin, prescription painkillers, and had no established protocol for tianeptine. The intake coordinators she spoke with had not heard of it. One treatment facility's medical director told her it wasn't a real addiction because the substance wasn't scheduled. Another facility accepted Tyler for evaluation, assessed his withdrawal symptoms, and administered buprenorphine, a standard opioid dependence treatment, because his presentation was clinically indistinguishable from opioid withdrawal. The buprenorphine helped, partially, temporarily. Tyler completed the 28-day program and came home to Wimbish Road in August. He stayed clean for 11 weeks. Desiree kept count. She had a small calendar on the refrigerator, the kind with squares large enough to write in, and she put a small check mark in each square each morning after Tyler came downstairs and ate breakfast, and the day began without incident. 11 weeks of check marks. Then she went to put a check mark in the square for a Wednesday morning in October and stopped. Something in the quality of the silence upstairs was wrong. She found 2 empty Zaza Red bottles in the bathroom trash. He had driven to a gas station in Warner Robins, 40 minutes away, outside the county where she had quietly asked most of the local stores to stop selling to him, the night before. She stood in the bathroom doorway for a moment. Then she went downstairs and made coffee. When Tyler came down, she didn't say anything. She poured him a cup and they sat across the table from each other in the morning light coming through the kitchen window. She kept the calendar. She erased the check marks and started over. The year 2017 introduced a new variable that accelerated everything: social media. The communities that had previously discussed Tianeptine on specialist forums, Erowid, Blue Light, Reddit's nootropics communities, were now being supplemented by content on YouTube, where individuals documented their Tianeptine use and withdrawal experiences in videos that accumulated hundreds of thousands of views. Facebook groups dedicated to Tianeptine users grew to tens of thousands of members. The content was not uniformly promotional. Many of the most viewed videos were cautionary, people documenting the horror of withdrawal, begging viewers not to make the same mistake. But the videos also, unavoidably, told viewers where to buy it. Poison control calls nationally reached 230 in 2017. The previous year had produced 120, the year before that, 80. The trajectory was not a gradual incline. It was an acceleration, each year's number roughly doubling the one before it, the kind of growth curve that epidemiologists associate with contagion events, not gradual adoption. The FDA's Center for Drug Evaluation and Research had, by 2017, received enough adverse event reports to open an internal review. The review assigned a team. The team requested information from vendors. Several vendors didn't respond. Those that did provided ingredient lists that were technically accurate and legally meaningless. The review took 2 years. During those 2 years, Ryan Kowalski's dose crossed 400 milligrams per day. Tyler Harmon relapsed twice more, and in Macon, Desiree Harmon began attending a support group for parents of people with substance use disorders, where she was the only person whose child's drug of choice could be legally purchased at a gas station. She started bringing bottles to the meetings. She would set one on the table at the beginning of each session and leave it there throughout, small, bright-labelled, and entirely legal, sitting among the folded pamphlets and styrofoam coffee cups, like an object from a different world that had wandered into this one. Nobody who saw it could quite believe it was real. France moved decisively in 2017, reclassifying Tianeptine as a List 2 controlled substance, the category requiring strict prescription controls, limited supply quantities, and mandatory prescriber registration for each new patient. The decision followed a formal review by the ANSM, the successor agency to AFSN-SAPS, which documented a consistent pattern of dependence cases in French addiction medicine over the preceding decade. The review cited 174 formal dependence cases reported through official channels, a number that French addiction specialists publicly described as likely representing a fraction of actual cases, given that most Tianeptine-dependent patients never reach specialist services. 174 formal cases. In a country where the drug was available only by prescription, dispensed only by licensed pharmacists, and monitored through a national health system with complete prescribing records. In the United States, where none of those conditions applied, there were no formal cases because there was no formal system counting them. What there was, a wire rack in a gas station on Route 18 in Akron, fully stocked, open 24 hours, accessible to anyone above the height required to reach the second shelf. And Ryan Kowalski, who drove past that gas station every morning on his way to school, who had recently switched from his online vendor to the retail bottles because the online vendor had begun requiring email verification for bulk orders, and who had calculated, with the precise, practiced arithmetic of someone who's been doing this math for a long time, exactly how many bottles he needed to buy each week to maintain his current dose. The number was 14. He bought them in 2 separate purchases at 2 separate gas stations so that no single cashier would see the full quantity. He had started doing this sometime in the fall of 2017. He could not, when he later tried to reconstruct the timeline, remember exactly when the 2 gas station system had begun. It had arrived gradually, like the dose escalation had. One small accommodation leading to another, each individually unremarkable, the total picture visible only from a distance he could not yet achieve. What he had not yet done was miss a day of teaching. That fact still meant something to him. He held on to it the way a person holds onto a handhold on a steep surface, not because it tells you anything about how far you might fall, but because it is for the moment solid. The moment was getting shorter. In the spring of 2022, a civil lawsuit filed in Fulton County Superior Court in Atlanta entered the discovery phase. The plaintiffs were families of Tianeptine victims, some survivors, some not. The defendants included 3 distribution companies and 2 retail chains that had stocked Zaza Red and its successor brands across Georgia between 2014 and 2021. Standard litigation in the context of the American opioid crisis landscape. Another lawsuit about another substance sold carelessly to vulnerable people. Then the documents came out. Discovery in civil litigation produces paper, emails, internal memos, sales projections, distribution records, meeting minutes, the operational sediment of a company's decision-making, preserved in servers and filing systems and suddenly made available to opposing counsel under court order. Most of it is mundane. Occasionally a document surfaces that reframes everything that preceded it. The document in the Fulton County case was a PowerPoint presentation, dated March 2016, prepared by the sales and marketing division of one of the defendant distribution companies. 17 slides. The first 12 covered standard business content, quarterly revenue, distribution expansion targets, competitor analysis. The 13th slide was titled Customer Retention Strategy. It contained a map of Georgia color-coded by county. The darkest counties, the ones the presentation identified as the highest priority expansion targets, were not the wealthiest. They were not the most populous. They were the counties with the highest rates of opioid prescription history and the highest rates of opioid treatment program enrollment. The presentation's authors had obtained this data from publicly available state health department statistics and overlaid it onto their distribution planning. The slide's header note read, "Repeat purchase rate 340% above baseline in target demographics, 340%. The next slide was worse. It detailed stocking recommendations, specifically placement height on retail racks, recommended proximity to the register, and suggested co-placement with energy drinks. One bullet point noted that bottles should be positioned at what the document called impulse range, between waist and shoulder height, rather than on lower shelves where browsing customers were less likely to make unplanned purchases. This was not a supplement company optimizing its shelf presence. This was a distribution operation that had identified, with clinical precision, the population most likely to develop rapid dependence on its product, mapped their geographic concentration, and built a stocking strategy around maximizing their repeat purchase rate. The presentation had been prepared by a 29-year-old marketing analyst. It had been approved by 2 senior vice presidents. It had been circulated to 6 regional sales managers, whose subsequent distribution decisions produced the saturation of Zaza Red across exactly the counties the map had highlighted. When the document became public through the litigation, it appeared briefly in regional Georgia news coverage. One Atlanta television station ran a segment. A local newspaper published a summary. it did not make national news. The week it was released, 3 larger stories were competing for attention, and the Fulton County discovery documents were dense and required explanation that 20-second segments couldn't contain. The document existed. The public record held it. It was simply never seen by most of the public. Ryan Kowalski did not see it either. By the spring of 2022, Ryan was no longer in a position to follow news cycles with any consistency. But the document's existence connects to something in his story that had been true since 2015 without his knowledge, because the vendor he had originally ordered from online, the one that had shipped him his first 10-gram bag in a padded envelope, was a subsidiary of one of the defendant companies in the Fulton County case. He'd been a customer in their database since February 2015. His purchase history, escalating quantities, increasing frequency, the switch from Tianeptine sodium to sulfate, the eventual transition to retail bottles, was recorded in their system with the same fidelity that any subscription service tracks its most valuable customers. He had been, in their terminology, a retention success. This is not a connection Ryan made. It is a connection that exists in the documents and in the timeline, visible only from outside the experience he was living. The map in that PowerPoint slide did something else that the news coverage missed entirely. It showed that the distribution strategy had been designed not around one region, but around a national template. Georgia first, as a proving market, with expansion plans for Mississippi, Tennessee, West Virginia, and Ohio already drafted in the appendix. Ohio, the state where Ryan Kowalski was buying 14 bottles a week from 2 separate gas stations. The appendix contained projected revenue figures for the Ohio market. It contained identified distribution partners in Columbus, Cleveland, and Akron. It contained a launch timeline beginning in the 3rd quarter of 2017. The gas station on Route 18 in Akron that Ryan had been visiting since late 2017 appeared by address in the distribution partner list in that appendix. The timing was not coincidental. The placement was not random. The wire rack beside the register, at impulse range, was the physical product of a documented commercial strategy targeting a population the company's own internal research had identified as maximally susceptible. Ryan had walked into that gas station for the first time in October 2017. The rack had been there for 3 weeks. Dr. Marta Vishnevska learned about the Fulton County documents through Christopher Hoyt, who sent her a summary in an email with the subject line, "You were right in 2006. She read the summary twice. Then she went back to her files and pulled the record of the phone call she had received shortly after her 2006 publication. The call from the medical affairs representative who had discouraged her from further research into Tianeptine dependence. The company that representative worked for, she now knew, had a documented commercial relationship with one of the Fulton County defendants. The relationship was a distribution agreement, formalized in 2012. The same year the representative had called her. She could not prove the call was coordinated. She could not prove it was anything more than routine post-publication outreach. The available evidence permitted no definitive conclusion. What it permitted was a question, a very specific one. The 2012 date mattered for another reason entirely, one that initially appeared unrelated and eventually proved central. In 2012, France formally reclassified Tianeptine under tighter prescription controls, the move that AFSS-APS had recommended after its 2003 review, and that had taken 9 years to complete. That reclassification reduced the volume of Tianeptine available through French legal channels significantly. Servier's French sales of Stablon declined. At exactly the same time, bulk Tianeptine exports from Chinese chemical manufacturers increased by a factor that trade data from 2012 and 2013 shows clearly. The Chinese manufacturers were not producing for the French market. which had just tightened. They were producing for a market that had no restrictions at all, the American supplement market. The tightening of European controls and the explosion of American grey market supply occurred in the same 18-month window. The companies building that American supply chain had been tracking the European regulatory environment closely enough to anticipate the opportunity. The 2016 PowerPoint's earliest market research appendix was dated November 2012, 2 months after France's reclassification took effect. This is the connection that reframes the entire American Tianeptine story. The crisis was not a spillover from a foreign drug culture. It was not an accidental consequence of the internet making obscure substances accessible. It was, in a specific and documented sense, a market that was constructed, deliberately, with research and planning and distribution infrastructure, in the window created by European regulation pushing the supply chain westward. The people who built that market knew what they were selling. The 2016 PowerPoint confirmed it. The 2012 timeline implied it. The documented targeting of opioid-affected communities made the logic explicit. Desiree Harmon did not have access to the Fulton County documents in 2018. What she had was Tyler, 23 years old, on his 4th attempt at sustained recovery, working part-time at an auto parts store on Riverside Drive, attending meetings 3 times a week. She had the calendar on the refrigerator, restarted again, check marks accumulating through the spring into a column that by June had reached 26 consecutive days. She also had, by this point, a habit she'd developed almost without noticing. Whenever she entered a gas station or convenience store, she scanned the racks near the register automatically. If she saw Zaza Red or any of its successor brands, she asked the manager to remove it. Sometimes they did. Usually they explained that it was a legal product and they had no obligation to remove it. She thanked them and left and wrote the store's name and address in a small notebook she kept in her purse. The notebook had 43 entries by the end of 2018. Each entry included the store name, the address, the brand of Tianeptine stocked, and the manager's response. She'd begun photographing the displays with her phone and organising the images by county. She did not know yet what she was going to do with any of this. She knew only that she was not going to stop collecting it. Tyler's 26th consecutive day became a 27th, then a 35th. The check marks continued up the calendar square by square, each one small and penciled and to Desiree enormous. She allowed herself to believe that summer that the worst was behind them. That belief was the most dangerous thing in her house. Ryan Kowalski missed his first full day of teaching in November 2018. He called in sick. He was not sick in any conventional sense. What had happened was simpler and more total. He had run out of Tianeptine at 11 p.m. the night before, his backup supplies depleted by a week in which his dosing schedule had become increasingly compressed, and the withdrawal had arrived by 2 a.m. with a force that precluded sleep, precluded planning, precluded everything except enduring the hours until the gas station opened at 6 a.m. He was there at 6:01. The cashier, a young woman who had seen him at this hour before, did not comment on the sweat soaking through his shirt collar, or the fact that his hands were shaking badly enough that he dropped his change on the counter and could not pick it up. She picked it up for him and placed it in his palm. He drove home. He took 4 bottles worth immediately, more than he had ever taken in a single sitting. The withdrawal retreated within 40 minutes. He lay on his couch and stared at the ceiling while the shaking subsided, and the thought that moved through his mind, not for the first time but with a clarity he had not previously allowed, was that he no longer recognized the shape of what was happening to him. He went back to school the next day. He stood in front of his classroom and discussed the causes of World War I with the same precision and engagement he had brought to that topic for a decade. Nobody in that room knew what the night before had looked like. and somewhere in Atlanta, in a filing system belonging to a distribution company that would soon be named in a lawsuit, a database record noted that customer account 7741-AK had made a retail purchase that morning at 6:01 a.m., flagged automatically by the system as a high-frequency buyer, assigned to the company's highest retention tier, and marked for priority restocking at his location. His location. As if the gas station on Route 18 belonged, in some operational sense, to him. In the way that mattered most, it did. March 2020. The world was shutting down. The COVID-19 pandemic arrived in the United States with a speed that overwhelmed every system it touched. Hospitals, supply chains, schools, the entire architecture of daily life that people had navigated without thinking about its fragility. For most Americans, the lockdowns of March and April 2020 represented an abrupt and disorienting disruption. For people dependent on substances, they represented something more specific and more immediately dangerous. The simultaneous collapse of every structure that had been, however imperfectly, holding things together. Addiction treatment clinics closed or moved to telehealth with days of notice. Methadone and buprenorphine programs, which required in-person dispensing under federal regulations that had never been updated for a pandemic, scrambled for emergency exemptions that arrived too slowly for the patients who needed them immediately. AA and NA meetings, the informal infrastructure that fills the gaps between formal treatment, vanished from church basements and community centres overnight. The social workers, the counsellors, the case managers whose caseloads had already been impossible before March 2020 were now operating through phone screens in their own isolated apartments. The gas station stayed open. They were essential services. Tianeptine sales in Georgia increased by 31% between February and April 2020, according to distribution records later submitted in the Fulton County litigation. In Ohio, a regional distributor's internal sales report for the second quarter of 2020 showed a 44% revenue increase over the same period in 2019. These were not the numbers of a product experiencing ordinary market growth. These were the numbers of a substance filling a vacuum, the specific vacuum created when every legitimate support system contracted simultaneously, and the only thing that hadn't changed was the wire rack beside the register. Tyler Harmon had maintained sobriety through the fall and winter of 2019. He had 387 days by the time March arrived. Desiree had switched from the refrigerator calendar to a sobriety tracking app that displayed the number prominently each morning when she opened it. 387 days. She'd shown him the number on his birthday in February, and he had looked at it for a long time without saying anything, the way a person looks at a large number they haven't yet made real to themselves. His meeting stopped on March 15th, when Georgia issued its first shelter-in-place order. His sponsor, a man he'd called every day for 14 months, had elderly parents in Savannah and relocated there within a week to help care for them. The telehealth therapist he'd been seeing bi-weekly had a 3-week wait list for new video appointments because her entire caseload had simultaneously entered crisis. Tyler was not new. He was existing. The system's triage put existing patients behind the acute ones. He lasted 6 weeks into the lockdown. The gas station on Riverside Drive was 4 blocks from the house on Wimbish Road. It stocked Neptune's Fix now. Zaza Red's distribution had been disrupted by litigation-related supply chain issues, and a different brand had filled the shelf. Different name, same active ingredient, same dose, same price. Desiree found the bottles on a Thursday evening. She did not start the counter over this time. She left the app on her phone unopened for 2 days. Ryan Kowalski's school went remote on March 16th. His classroom, which had been the last functioning structure in his daily life, the one context where the discipline of maintaining appearances had imposed a kind of external order on an internal situation that had long since lost any, was now a laptop screen in his apartment. The laptop was on his kitchen table, 3 feet from the amber jars. Without the commute, without the schedule, without the physical act of standing in front of 30 students and being Ryan Kowalski, the history teacher, the intervals between doses began to compress. The 2.5-hour window he had maintained through a system of pre-measured packets and timed alerts on his phone began to collapse. He was dosing every 90 minutes by April, every hour by May. The jars emptied faster than he could restock them, and the gas stations were now part of a daily circuit he drove, not because he needed other supplies, but because the restocking had become the primary organizational principle of his day. He taught his remote classes. He was on screen, visible, present. His students noticed nothing except that he seemed tired, which was true of every teacher in America that spring. His hands were shaking in most of those sessions. The camera resolution was low enough that it didn't show. The FDA had been moving, slowly, by the standards of the crisis unfolding in real time, but moving. In January 2020, the agency had published a formal warning letter to a major Tianeptine distributor, citing the substance's opioid receptor activity, its abuse potential, and its marketing as a dietary supplement as violations of federal law. The letter demanded the company cease distribution within 15 days. The company's legal team responded within the deadline with a 40-page document arguing that Tianeptine met the definition of a lawful dietary supplement under DSHEA, that the FDA's characterization of its pharmacology was disputed, and that the agency's warning letter exceeded its statutory authority under existing supplement regulation. The FDA had no immediate legal mechanism to override this response unilaterally. The DSHEA framework, the same 1994 law that had created the regulatory gap, required the agency to demonstrate that a supplement posed an imminent hazard to public health before it could act without going through the full rulemaking process. The rulemaking process took years. The imminent hazard standard was legally demanding. The distributor's lawyers knew both facts precisely. The distributor kept selling. The FDA began preparing an import alert, a tool that could block Tianeptine from entering the country at the border, targeting the Chinese bulk supply chain rather than the domestic distributors. This process also took time. The documentation requirements were extensive. The interagency coordination required was slow. While the documentation was being assembled, the pandemic happened. The FDA's enforcement resources redirected sharply toward COVID-19 related priorities. The Tianeptine import alert moved to a secondary queue. It stayed there for 2 years. Tyler Harmon died on the morning of May 14, 2020. He was found by Desiree at 8:47 a.m. when she knocked on his bedroom door to tell him breakfast was ready and received no answer. He was 24 years old. The Bibb County Medical Examiner's report listed the cause of death as mixed drug toxicity. The toxicology screen identified tianeptine as a primary contributing substance, alongside a small amount of alprazolam, an anti-anxiety medication Tyler had obtained, Desiree later learned, through an online pharmacy that required no prescription verification. The alprazolam had been his attempt to manage the tianeptine withdrawal on his own. He had read on a forum that benzodiazepines could ease the symptoms. The combination, in the quantities his system contained at the time of death, had suppressed his respiratory drive below the threshold of survival. He had been trying to quit. Desiree called 911. She waited on the front porch while the ambulance came. She was still holding the coffee mug she'd been carrying when she knocked on his door. She did not put it down until a paramedic gently took it from her hand on the steps. The paramedic later told a colleague that the mother had seemed completely calm. She was not calm. She was somewhere beyond the reach of the expressions that calmness and its opposite are made of. The death certificate listed Tyler's address as the house on Wimbish Road in Macon, Georgia. In the field for occupation, it listed retail sales associate. In the field for contributing conditions, in small typed text below the primary cause, it said, history of substance use disorder. It did not say, Tianeptine was legally purchased from a gas station 4 blocks from this address. It did not say, the substance had never been approved by the FDA. It did not say, the company that supplied that gas station had a documented strategy targeting opioid-affected zip codes, and Tyler's zip code was in their top quartile. Death certificates don't contain that kind of information. They contain what the medical examiner can certify. The rest goes elsewhere, or nowhere. Desiree read the certificate 4 times the day it arrived. Then she put it in a folder with Tyler's hospital records from his 2016 treatment admission, his discharge paperwork, his toxicology report, and a photograph of him at 17, standing in a John boat on a lake in the North Georgia mountains, holding a largemouth bass up to the camera with both hands, and grinning in the way that people grin when they are genuinely happy, and have not yet learned to perform happiness for an audience. She put the folder in her bag. She has carried it with her every day since. Ryan Kowalski's seizure happened on a Tuesday morning in March 2021 in his apartment kitchen, 11 months after the pandemic lockdowns began. He had been awake for 31 hours, his dosing schedule having fractured into a continuous wakeful state, punctuated by consumption rather than organized around it. His total daily intake had reached levels that his body, even now adapted to extraordinary quantities, could no longer metabolize in any stable equilibrium. He was found by his neighbor, a retired postal worker named Gerald, who lived in the adjacent unit and had heard a loud impact through the shared wall at 7:14 a.m., followed by silence. Gerald knocked, received no answer, tried the door, which was unlocked, found Ryan on the kitchen floor beside the counter, the amber jars above him, conscious but unable to speak coherently, his left arm moving in a repetitive motion he appeared unaware of. Gerald called 911. He sat on the floor next to Ryan and held his hand until the paramedics arrived, because it seemed like the right thing to do, and Gerald was the kind of man for whom the right thing arrived as instinct rather than calculation. The ER at Summa Health Medical Center in Akron received Ryan at 7:52 a.m. The attending physician that morning was Dr. Sandra Osei, 7 years out of residency, experienced with opioid overdose presentations, deeply familiar with the consequences of the regional drug crisis that Akron had been living with for a decade. She reviewed his symptoms, his vitals, his altered mental state, and asked the standard triage questions. When she reached the question about current medications or supplements, Gerald, who had stayed, who had ridden in the ambulance, who didn't know Ryan well but knew him well enough to understand that he should not be left alone, mentioned the jars on the kitchen counter. He described the labels. Dr. Osei did not recognize the product. She typed the name into her phone's browser at the nursing station. The search took 4 seconds. The first result was a vendor site with a 5-star rating and a Buy Now button. The second result was an FDA warning letter dated January 2020. She read the warning letter standing at the nursing station, the phone in one hand, Ryan's chart in the other. The pharmacology it described, the opioid receptor activation, the short half-life, the withdrawal profile, mapped precisely onto what she was looking at on the gurney 15 feet away. She ordered buprenorphine. She called the addiction medicine consult. She opened a second browser tab and found the poison control literature, Hoyt's 2014 paper and several subsequent case series published through 2019, and read through them in the 20 minutes before the consultant arrived. In those 20 minutes, She learned more about tianeptine than most American physicians knew in 2021. Everything she learned had been available since 2014. Some of it had been available since 2000. The national numbers that year told a story that could no longer be managed in regional increments. The CDC's 2021 drug overdose surveillance data showed tianeptine as a contributing substance in a statistically significant and rapidly growing number of deaths, the exact figure complicated by the persistent undercounting that resulted from toxicology screens that didn't routinely test for it. 17 states had now restricted or banned tianeptine. Federal scheduling remained absent. The online market had fragmented into dozens of vendors using new brand names, new formulations, new legal arguments about molecular variants that fell outside existing state bans. The poison control total since 2014 stood at 1,338 documented calls, a number that researchers at the National Poison Data System publicly described as a significant underestimate, given that most tianeptine-dependent people never contacted poison control at all. At least 11 deaths had been formally linked to tianeptine in the United States. Toxicologists working in the field estimated the true number was higher by a factor they were reluctant to specify, because the data infrastructure for tracking unscheduled supplement-related deaths did not exist with sufficient granularity to support a confident multiplier. 11 confirmed, an unknown multiple of that unconfirmed. In Macon, Georgia, one of the confirmed was a young man in a john boat holding a fish. In Akron, one of the survivors was lying in a hospital bed, 14 days of medically supervised withdrawal ahead of him, a retired postal worker sitting in the chair beside the bed reading a 2-day-old newspaper because he had nowhere better to be. Ryan was conscious. He was not in withdrawal. The buprenorphine held at a distance, a pharmaceutical arm's length from the worst of it. He lay in the bed and looked at the ceiling tiles and thought, with a clarity that had not been available to him in years, about the wire rack in the gas station on Route 18, and the Tuesday night Reddit thread, and the amber jar in the kitchen drawer, and how each individual step from one to the next had been, at the time it was taken, comprehensible. The comprehensibility was what he couldn't stop thinking about. Not the loss of control. He had a framework for that now, from the addiction counsellor who had visited that morning, and the framework helped. What he kept returning to was the coherence of the path that had led here. Each decision had made sense within the situation that produced it. The dose increase the February had been reasonable given the plateau. The bulk order had been economical. The 2-gas station system had been practical. The logic had been intact all the way down. He was still thinking about this when Dr. Osei came in for afternoon rounds and found him staring at the ceiling with his hands folded on his chest, completely still, in the particular stillness of a person who has arrived at a question they cannot yet formulate. She asked how he was feeling. He said he wasn't sure yet. That was the most accurate thing he had said in years. Ryan Kowalski spent 14 days in Summa Health's addiction medicine unit. The buprenorphine taper was precise and carefully managed. Dr. Osei had consulted with a specialist in Cleveland who had treated 3 other tianeptine cases, and together they built a protocol from the available literature and clinical judgment, because no standardized tianeptine withdrawal protocol existed anywhere in American medical guidelines at the time. They were writing the procedure as they performed it, adjusting the buprenorphine doses against Ryan's symptoms each day, charting everything with the thoroughness of people who knew they might be building the reference document for the next physician who encountered this. The first 3 days were the hardest, not because the medication failed, it didn't, but because the medication's effectiveness created space for the mind to reconvene, and what reconvened was everything Ryan had spent 6 years not examining directly. The shape of the last 6 years was visible from the hospital bed in a way it had not been from inside them. He lay in the institutional light and let the shape be what it was. Gerald came every day. He brought a newspaper he had usually already read, and he sat in the chair by the window, and he didn't ask questions that required answers. This was, in Ryan's later accounting, the most useful thing anyone did for him during those 2 weeks. On day 9, Ryan asked the addiction counsellor for a pen and a legal pad. He wrote for 3 hours. The counsellor, reading it later with Ryan's permission, said it was the most detailed self-inventory she had received from a patient in 11 years of practice. Not because it was dramatic, but because it was precise. Ryan had been a history teacher for a long time. Precision with chronology was the only skill he had that the previous 6 years had not degraded. He was discharged in late March 2021 into an outpatient program that met 4 times a week in a church annex in Cuyahoga Falls, 12 miles from his apartment. He moved to a new apartment first. The one on the street with the gas station was vacated within a week of discharge, his lease broken with a penalty he paid without negotiating. The new apartment was on the 3rd floor of a building whose ground floor held a dry cleaner, a tax preparation office, and a nail salon. No rack by any register, no wire shelf in his sight line. He had been told by the addiction counsellor and by 2 separate physicians that tianeptine's neurological footprint in heavy long-term users could take months to fully resolve, that the glutamate modulation and structural changes the drug had produced in his brain over 6 years would not reverse in 14 days, that the anxiety he would feel in the first weeks of sobriety was partly the original condition returning and partly something the drug itself had created through long-term neuroadaptation. The two were not easily distinguished from each other. He felt anxious every day for the first 4 months. He took no medication for it. His psychiatrist offered options. He deferred, for reasons he couldn't fully articulate except to say that the act of taking something felt, for the moment, like something he needed to stay away from. His psychiatrist accepted this and scheduled weekly check-ins. He ran 3 miles on a Thursday morning in June 2021, the first run since a morning in 2017 he couldn't precisely place. The same route, along the towpath beside the Cuyahoga River. He stopped once at the halfway point, not because he was winded, but because the light on the water was a specific colour that he recognised from somewhere before all of this, and he stood there until a cyclist came through and he stepped aside. The FDA's import alert, alert number 66-110, targeting tianeptine sodium and tianeptine sulfate, was published in February 2022. The alert authorised US Customs and Border Protection to detain shipments of these specific tianeptine compounds at the point of entry, effectively severing the Chinese bulk supply chain that had fed the American market for nearly a decade. The action was significant. It was also narrowly targeted. It covered 2 specific salt forms of tianeptine and left other molecular variants in an unaddressed grey zone that several vendors immediately began exploiting. Within weeks of the import alert's publication, online forums were documenting the availability of tianeptine-free acid, a different chemical form of the same compound, from vendors who had anticipated the import alert and diversified their supply chains accordingly. The free acid form was not covered by Alert 66-110. The FDA was aware of this gap. Closing it required a separate regulatory action, which was initiated but not completed within the same year. The vendors had tracked the regulatory process closely enough to stay 1 step ahead of it. The same supply chain intelligence that had monitored European reclassification in 2012 and built American distribution infrastructure in the resulting window was monitoring the FDA's rulemaking in 2021 and adapting accordingly. The game had not ended. The board had changed slightly. Georgia's state legislature passed the Tianeptine Consumer Protection Act in March 2022, making it one of the most comprehensive state-level tianeptine restrictions in the country. The law scheduled all tianeptine forms as controlled substances, imposed criminal penalties on knowing distribution, and, crucially, included a civil liability provision that allowed victims or their families to sue distributors who had knowingly sold tianeptine to Georgia residents after a specified date. That civil liability provision was the provision that made the Fulton County lawsuit viable. It was also the provision that produced the discovery documents, the PowerPoint, the county map, the retention strategy data that had been sitting in a corporate filing system since 2016. Desiree Harmon had testified before the Georgia House Health and Human Services Committee in January 2022, 2 months before the bill passed. She had brought the folder, Tyler's hospital records, the death certificate, the photograph from the lake. She had placed them on the table in front of her and spoken for 9 minutes without notes, in the particular register of a person who has told a story so many times that it has acquired a structural integrity that requires no preparation. The committee members were quiet throughout. One of them, a representative from Bibb County who had known Tyler's baseball coach, did not look at the papers on the table. He looked at Desiree the entire time. The bill passed the full legislature with no opposing votes. Dr. Marta Wisniewska's 2006 case series had accumulated, by 2022, 41 citations in peer-reviewed literature, nearly all of them from 2019 onward, as the American crisis drove a surge of interest in the pharmacological record that had existed and been largely unread for over a decade. A research team at Johns Hopkins cited it in a 2021 review paper that synthesized everything known about tianeptine dependence across all published sources. The review was published in the Journal of Addiction Medicine and was accessed in its first 6 months over 12,000 times, a number that reflected the hunger of American clinicians for guidance on a substance they were suddenly seeing regularly, with no training to address it. Wisniewska's own 2021 paper, a follow-up to her original case series, now expanded to 47 patients tracked over 15 years, was published in European Psychiatry and cited within 3 months by researchers in the United States, Brazil, Russia, and Australia. The international distribution of citations mapped almost exactly onto the international distribution of tianeptine markets. She'd been right in 2006. The literature now said so explicitly, with thousands of citations she didn't have and could not have had when a man she didn't know called to suggest her sample was too small. She kept the record of that call in her files. Not for legal purposes. There was no legal action she could take, no jurisdiction she could pursue, no statute that addressed what had been, technically, a phone call. She kept it because the record was accurate, and accuracy had been her discipline for 30 years, and some accurate things deserve to be kept even when they go nowhere. Across 23 states by the end of 2023, tianeptine was scheduled as a controlled substance. The federal status had not changed. It remained unscheduled at the DEA level, not approved, not banned, occupying the same federal grey zone it had inhabited since the first gram was sold in an American supplement shop sometime around 2013. The FDA's enforcement actions had created meaningful supply disruption for the most visible retail products. The Zaza Red brand had been absent from Georgia shelves since 2022. Online, the market persisted. Different names, different formulations, different vendors operating from different jurisdictions. A search for tianeptine on any major e-commerce platform in early 2024 returned results, some from vendors based outside the United States, some from domestic sellers who had passed the regulatory language carefully enough to remain technically compliant with existing restrictions. The wire rack in the gas station on Route 18 in Akron was empty of tianeptine products by late 2022, after Ohio added tianeptine to its controlled substance list in August of that year. The store owner removed the bottles without comment and filled the space with a different supplement, one he had received from a distributor who described it as natural mood enhancer. The owner didn't know what it was. He knew it was legal, it fit in the wire rack, and the distributor had told him it sold consistently. The supplement's active ingredient was not tianeptine. What it was is a question the available record answers in a way that does not provide relief. Ryan Kowalski returned to teaching in the fall of 2021 at a high school in Medina, a different district, a different building, a fresh institutional context in which none of his colleagues knew what the previous spring had looked like. He requested a sophomore world history section and a junior American history section. Familiar material, stable ground. He didn't tell his new colleagues about his medical history. He was not required to. His physician had cleared him for full-time work. His addiction counsellor had discharged him from the outpatient program in August, with documentation of completed treatment. He was, by every formal measure, recovered. What recovery looked like from the inside, waking each morning and taking 30 seconds to notice that the monitoring was gone, the clock that had run behind every thought for 6 years, counting down to the next dose. Its absence did not feel like freedom exactly. It felt like silence where something loud had been, which is its own kind of adjustment. He had been told this was normal and that it diminished over time. It diminished. Slowly. In the way that the imprint of something very heavy and soft ground doesn't disappear with the removal of the weight, but rather slowly, over months, becomes less precise. He kept a photograph of Gerald on his desk. Not a posed photo, just a picture Ryan had taken with his phone one afternoon in the church annex parking lot. Gerald leaning against his car in the afternoon light, not looking at the camera. Gerald had not asked to be photographed and had expressed mild bafflement when Ryan showed him the result. Ryan had framed it anyway. He could not fully explain the impulse, even to himself. Some things anchor you to your own life at a moment when the anchorage matters, and the specifics of why are less important than the fact that it holds. Desiree Harmon drove to the Georgia state capitol in Atlanta on the morning the Tianeptine Consumer Protection Act was signed into law. She stood in the gallery above the governor's desk. She had the folder with her, in the bag on her shoulder, the way she always did. After the signing, a legislative aide she had worked with through the process found her in the hallway and told her that her testimony had been specifically cited by 3 committee members as the moment the bill's passage became certain. She thanked him and walked down the marble stairs to the parking garage and sat in her car for 22 minutes before starting the engine. She did not think this was justice. She did not think Tyler would have used that word either. She had known him well enough to know that he had never been particularly interested in abstract categories. He had been interested in the lake and the fish and the way the early morning light came across the water when there was no wind. The law had his name in it now, in the committee report's finding of fact section. One of 11 documented fatalities cited to establish the public health emergency the legislation was designed to address. His name in a legal document, in a finding of facts, next to a cause of death. She started the engine and drove home to Macon. The folder was on the passenger seat beside her, the photograph visible through the half-open flap. Tyler's grin facing upward at the Georgia sky moving past the window at 65 miles an hour. The calendar app on her phone, unopened since May 14th, 2020, still showed the last number it had recorded, 387 days. She had not deleted it. She had not looked at it. Both of those things were true simultaneously, and the tension between them had no resolution she'd found, and she had stopped looking for one. The road south ran straight and flat through the Georgia pines, and she drove it the way she had driven everything since that morning. Forward, because that was the only direction available, with the folder on the seat beside her, and the question of what came next still entirely open. The wire rack on Route 18 in Akron is still there. That is not a metaphor. The physical object, the rotating metal display mounted beside the register, the one that held 14 bottles a week for a man in a grey fleece jacket who paid cash and didn't make eye contact, is still bolted to the counter of the same gas station where it has always been. Ohio scheduled Tianeptine in August 2022. The Zaza Red bottles and the Neptune's Fix bottles and every other bright-labelled Tianeptine product disappeared from that rack within days of the law taking effect. The rack itself was never removed. It was restocked. The store owner ordered the replacement product from the same regional distributor who had supplied the Tianeptine brands. The distributor offered several alternatives. The owner chose the one with the best margin and the most attractive label, a product called Calm Wave, marketed as a natural stress support supplement, available in the same small bottle format, priced at $17.99. Positioned at the same height on the same rack in the same location beside the same register where the Tianeptine had been. Calmwave's active ingredient was listed on the back label in the same small font that supplement labels always use for things they'd prefer customers not examine too closely. The ingredient was kava extract, a plant-based compound with genuine anxiolytic properties and a well-documented profile of liver toxicity at high doses. Beside it on the ingredient list, phenibut, a synthetic compound developed in the Soviet Union in the 1960s, used clinically in Russia and Eastern Europe, never approved by the FDA, carrying a dependence profile that addiction specialists had been documenting in American patients since the mid-2000s. Phenibut acts on GABA receptors, the same receptor system targeted by benzodiazepines like Valium and Xanax. Its half-life is short. Tolerance develops within days of regular use. Withdrawal is severe, potentially dangerous, and clinically similar to benzodiazepine discontinuation syndrome. It is not scheduled at the federal level. It is not approved as a drug. It is, under DSHEA, a dietary supplement. Between 2019 and 2023, the FDA received more than 1,000 adverse event reports for phenibut-containing products. The rack hadn't changed. Only the bottle had. This is the thing about Tianeptine that its own story almost obscures. It was never the point. It was an instance. A specific, documented, unusually well-evidenced instance of a process that predates it, that produced it, and that continued uninterrupted after the states banned it, and the FDA blocked its imports, and the litigation documents entered the public record. The process is this. A pharmacologically active compound with abuse potential, either developed legitimately elsewhere or synthesized specifically for the purpose, enters the American supplement market through the regulatory gap that DSHEA created in 1994 and has never closed. It is sold in brightly labelled bottles at impulse buy height, in the retail locations most accessible to the populations most likely to develop rapid dependence. It produces a customer base with the highest repeat purchase rate in the supplement industry. When regulatory action eventually arrives, years after the first clinical warnings, after the first deaths, after the first state bans, the supply chain has already identified the next compound. The gap is not a flaw in the system. At this point, given the documented history, it functions as a feature, a space that is consistently and deliberately occupied by products designed to exploit its existence. DSHEA has been in force for 30 years of documented instances. Tianeptine is the most thoroughly evidenced. It will not be the last. Ryan Kowalski teaches sophomore world history and junior American history at a high school in Medina, Ohio. He is, by every available measure, a good teacher, the kind students come back to visit, the kind whose evaluations contain words like engaging and prepared and genuinely cares. His hands do not shake in the morning anymore. The monitoring that ran behind his thoughts for 6 years is, 4 years into his recovery, present only occasionally, a ghost of a clock rather than a functioning one. He does not talk about Tianeptine to his students. He's not obligated to, and there is no curriculum for it, and the gap between what he lived and what a 16-year-old in a history class can usefully receive is not a gap he has found a way to bridge. What he does every year in the unit on the 1990s is spend one full class period on the Sackler family, OxyContin, and the architecture of the American opioid crisis, the regulatory decisions, the marketing strategies, the gap between what the manufacturers knew and what the public was told. He teaches it the way he teaches everything, with primary sources, with specific dates, with the documents that show what the people inside the decisions knew and when they knew it. His students, uniformly, find this the most interesting unit of the year. They ask questions that take the period past its end time. They want to know how something so visible could have been invisible for so long. They want to know who was responsible and whether anyone was held accountable, and what happened to the people caught inside it. Ryan answers the questions he can answer with the specificity they deserve. For the ones that don't have clean answers, he says so directly. Because one of the things that 6 years inside a pharmaceutical catastrophe teaches, if it teaches anything, is that the questions without clean answers are often the most important ones to keep asking. He has not updated this unit to include Tianeptine. He has thought about it. He has not done it yet. Desiree Harmon is still in Macon. She works 3 days a week as a patient advocate at a substance use treatment facility on 2nd Street, a position she took in 2022 after the Georgia bill passed, because the work of sitting in government hallways with a folder had clarified something she had not previously known about herself, that she was better at this than almost anything else she had tried. She knows the intake coordinators at every treatment facility within 40 miles. She knows the emergency room nurses at the medical center of Central Georgia by name. When a family calls the facility's intake line not knowing where to start, she is frequently the person who takes the call, because the staff have learned that her particular combination of knowledge and tone, comprehensive and completely without condescension, produces an outcome that the standard intake script does not. She still carries the folder. It is with her at the facility every day she works, in her bag under her desk. She does not take it out regularly. Occasionally, when a family's in the particular kind of crisis that fact can help rather than hurt, she opens it and shows them Tyler's toxicology report, which lists Tianeptine specifically and which she can explain in accurate pharmacological terms, because she has spent 4 years learning to explain it. She shows them the report, then she shows them the photograph. The photograph is the last thing she shows them, and she shows it last deliberately, because she has learned that the medical document communicates the mechanism, and the photograph communicates everything the mechanism doesn't capture. The specific person, the specific light, the specific grin, the base held up with both hands. The thing that was lost that cannot be entered into a finding of facts. Dr. Marta Wisniewska retired from clinical practice in Bucharest in 2023 at the age of 62. Her patient files, 30 years of them, carefully maintained in a system she had developed herself, cross-referenced by diagnosis, medication, and outcome, were transferred to her successor at the clinic. The Tianeptine files, flagged specifically, were the ones she handed over in person, with a verbal summary of each case that her successor recorded and transcribed. She still corresponds occasionally with Christopher Hoyt, whose own career has moved increasingly toward regulatory advocacy, working with state health departments and more recently with FDA advisory panels on the broader question of supplement safety framework reform. Their emails are infrequent and professional. Occasionally one of them sends a newly published paper without comment. The other responds with a single line of acknowledgement. The collaboration that began with a 2014 email exchange and a 4-second Google search has produced between them 9 co-authored papers, 2 invited congressional testimonies, and a combined citation count that neither of them tracks. The phone call Vishnevska received in 2006 remains in her files. The record she made of it is accurate, specific, and, in the current state of the law, actionable for no one. She kept it anyway. Some records exist not because they will be used, but because discarding them would be a different kind of inaccuracy, an erasure of something that happened, dressed up as tidiness. The FDA's import alert on tianeptine sodium and sulfate remains in effect as of early 2024. The DEA has not scheduled tianeptine at the federal level. The DSHEA framework remains intact, substantively unchanged from the version that passed in 1994. Congressional efforts to reform supplement regulation have been introduced in multiple sessions and have not advanced past committee in any of them. The supplement industry's lobbying infrastructure, which spent $146 million on federal lobbying between 2010 and 2022, remains one of the most consistently effective in Washington. 23 states have restricted tianeptine. 27 have not. In those 27 states, tianeptine in various formulations remains available. Online vendors operating from jurisdictions that fall outside existing enforcement reach continue to accept orders and ship product. The forums that documented the first recreational use in the early 2000s still exist, still contain the dose information, still contain the warnings that are read by people who believe, with the particular confidence of people encountering something for the first time, that the warnings apply to other people. The number of tianeptine-related poison control calls in 2023 has not been published at the time of this account. When it is published, it will be higher than 2022. That is not speculation. It is the direction every annual data point in this story has moved since 2014, without a single exception. Return to October 2019 for a moment. Route 18 in Akron. The man in the grey fleece jacket, 3 bottles of Neptune's Fix, cash on the counter, hands already shaking. That man is Ryan Kowalski. You know that now. You know what the shaking meant and what the 3 bottles represented in the arithmetic of his day. You know what the gas station's rack was doing there, who put it there, what the PowerPoint said, what the county map showed, and what the distributor's database recorded when he walked out the door. You know what he didn't know at the time, which is nearly all of it. He survived. That is a fact worth holding, in a story where not everyone did. He survived, and he teaches, and he runs along the towpath in the morning, and occasionally stands still when the light on the water is a colour he recognises from before. What he lost: 6 years, a marriage that ended before the tianeptine but whose aftermath the tianeptine occupied completely, a version of himself he can describe in retrospect but cannot fully recover because recovery is not retrieval, is not recoverable. That is also a fact. The gas station on Route 18 is open right now. The rack is beside the register. The bottles on it are not tianeptine. The person who designed that rack's placement, who chose that height, who mapped the zip codes and calculated the repeat purchase rate, and put the product at impulse range for a population they had specifically identified as maximally susceptible. That person has not been charged with a crime. The civil litigation continues. The legal process moves at the pace legal processes move. The rack stays stocked. There is a number that has not appeared yet in this account, held back because its proper place is here at the end, where the full weight of the story makes it land differently than it would have at the beginning. Between 1994, when DSHEA passed, and 2024, the FDA identified and took formal enforcement action against substances sold as dietary supplements that were later found to carry serious, undisclosed health risks. The number of such substances in that 30-year period is not a small one. It is not a manageable list of isolated incidents. It is over 700 compounds, 30 years, the same legal framework, the same regulatory gap, the same process. Compound enters the market, accumulates users, generates adverse events, triggers a slow regulatory response, gets restricted or banned, is replaced by the next compound, which enters the market, accumulates users, and so on. 700 entries in the catalogue. Tianeptine is one of them. The catalogue is not closed. In a warehouse in a state with no tianeptine restriction, a distributor's inventory system shows current stock levels, reorder triggers, and regional sales projections for 17 supplement products, 3 of which contain compounds that have not yet attracted regulatory attention. The system flags one of them as the fastest growing SKU in the portfolio for the 3rd consecutive quarter. The sales manager reviews the flag, approves an increased production order, and moves on to the next item in the queue. The bottle hasn't been named yet. The story has already begun.